All right, go ahead.
Hi, everyone. We are Team 3. My name is Abbie Delaney, she, her, and I'm currently in my third year of a Bachelor of Science in Kinesiology.
My name is Olivia Hamilton. I am in Renaissance College taking a biology minor, and she, her.
My name is Thomas Kean. I go by he, him pronouns. I'm in my third year of the Bachelor of Business Administration program, majoring in finance and economics.
My name is Christianne Malaty. My pronouns are she, her, and I'm in my first year of nursing.
First, we will start off with our short-term goals, which we have broken into two categories here. Our first one is the hospital resources, which we believe weren't used to the full potential in the case that we were given. So in this category here, we have first the social worker. They should have been called during Amina's first visit, and they shouldn't have waited till the second visit, so she could have got connected to those support systems outside of the hospital. And the second one is the diagnostic testing part. They should have done more proper tests to ensure the proper diagnosis was given, as research does show that patients with low English proficiency are at a high risk of physical harm as a result of medical error. And the last part of this one is the pharmacist. They should have connected her to a pharmacist so she knew all about the medication she was given, instead of assuming that she had internet access to search it on her own. Research does show that those who come from a low socioeconomic status receive less information about the diagnosis process. This leads to a lack of partnership between the patient and the healthcare professional, which does lead into our second category here, which is the patient relationship. Amina should have left that hospital with trust in her medical team and feeling heard and understood, and leaving with a positive experience. But instead, she was treated as a nuisance, and there should have been someone to occupy her children as well to ensure she got the full attention that she needed. A simple pen and paper would have done just to occupy them while they handle her situation. She should feel like she can come back to the hospital if needed.
I'm going to talk about this the 3-year long-term plan. So for us, we're using an information campaign, and the purpose of using this information campaign is to educate and connect newcomers to pre-existing resources and let them know what services are available to them. Along with this, the information campaign targets nurses and other healthcare workers in making new resources centered around newcomer healthcare and the challenges this group might encounter when interacting with the healthcare system. The goal is to improve both the physical health of newcomers and refugees with providing more accurate diagnoses by bridging language barriers and creating a more patient-centered approach, but with newcomers, and improve trust and overall opinion of the healthcare system so they feel comfortable in returning if problems do arise in the future. Okay. So we have 4 main target areas in our approach. We have a pictorial tool aimed at bridging language gaps. We have an expansion on language support. We have an emphasis on existing services and social worker utility, and creating new educational programs on newcomer-centered healthcare.
So the first aspect of our new campaign is to create a pictorial tool. So this will help patients describe the symptoms that they're feeling regardless of any language barrier. And this is based off of triage, physical assessment, and non-Western pain semantic research. So for example, this is a chest pain triage. If someone has heartburn, they might point to the blue box. If someone has anxiety, they might point to the green box. And if someone had a heart attack, they might point to the drawings in the pink box, whereas they all could generally be described as chest pain. The next element of our campaign is to increase language support. So medical interpreters have been proven to improve health outcomes. This can involve increasing preventative care, decreasing hospitalizations, and so much more. So there's about 2 ways to go about it. There's the outsourcing, which I would suggest a company such as Can Talk, which is phone interpretation with trained healthcare interpreters and document translation. And then on the kind of backup, and there'd be a Pocket Talk, which would be an AI-based translation device. And then this would be more similar to the Mackenzie Health model in Ontario because it's all outsourced. Alternatively, you could also have an in-source model, which is more similar to the Provincial Health Services Authority model in BC, and then this would just involve expanding the translation department.
Another part of our 3-year campaign is the services that the government of New Brunswick does offer for newcomers. Their website does have a pre-checklist of steps that newcomers must take before arriving and directs them on how to obtain all the things that they need. As well, they have plenty of services for newcomers when they're here, such as orientation sessions, English classes, conversation groups, and many more, which you can see in the list there over to the side. And the last one is, again, the use of social workers, which we did touch on briefly earlier. We plan to educate healthcare workers to use this resource more, as they are part of the healthcare team and can help newcomers navigate life in their new home, as well as provide a link between the healthcare team and the family.
All right, so the next element is the education element. So we're approaching that education element at 2 levels. So the college, university, graduate level. So this would be targeting students in a Bachelor of Nursing, or I know New Brunswick doesn't really have a med school, but there's one associated with DAL, as well as just other healthcare professions. So this would be worked into the program as a class. We are aware that we learn about cultural safety, trauma-informed care, and communication skills. However, we're not really taught how to handle certain situations, nor are we made aware of the unique situations we may put in, especially when it comes to language barriers and newcomers. The next level will be the institution level. So Horizon Health, for example, has yearly e-modules that volunteers and employees are required to do in order to work for that year. So we would create an e-module essentially targeting all these issues and just how to handle these situations, and just making the healthcare professionals aware of what resources are around in Horizon for things such as language. So for this, we would have a quiz within the e-module to ensure that people are retaining the most information as possible. So we really believe in the education element, because it wasn't even until 2015 when the Truth and Reconciliation Committee made it a requirement for healthcare professionals to take a course on Indigenous health. And because there's such a great population of newcomers in Canada, we feel that it would be very beneficial.
Okay, and then I'm going to talk about the cost estimation of language services first. So we have, as we talked about earlier, Pocket Talk. It's about $130 per unit for the classic model. It would need about 3 units for a hospital the size of Upper River Valley Hospital, and of course more needed for larger hospitals. The benefit for this is that it is a fixed one-time cost and that you only have to pay once. With the phone interpreter, the cost is more varied, as it ranges from $1.25 to $3 a minute. That's based on demand in languages and also when they're to be called. A benefit for this is that there's no infrastructure needed, and if you end up using less than you would pay for a unit of the Pocket Talk, then you're down on expenses. And then we're going to talk about the creation of the e-module. So creation of e-modules, the costs vary pretty greatly. They can range from as low as $4,500 to up to $22,000, depending on the amount of expertise employed. A lot of the variables in this cost would include hourly rates, the time spent at creation, the amount of complexity and interactivity that one would want.
All right, so just for our timeline, sort of. So we feel that it would take about a year to prepare everything, assuming we have the correct team and the correct resources available to us. And after that, because it's an information campaign, we're hoping to get everything out right away as soon as possible to really start that behavior change in people and get their mindsets changing. So we will, throughout the 3 years, we will constantly and formally be evaluating the campaign and immediately fixing any problems that may arise. And then at the 3-year mark, we will conduct a formal evaluation to ensure everything's working smoothly and see if there are any long-term effects and if we see any change happening. So a campaign is really just something that's used all the time. I just like to think of it as a big advertisement. So we're really trying to get our resources out there and show what's available and just really start changing that behavior that people have. So this campaign does work in accordance with the social determinants of health as we're targeting the newcomers, their arrival, pre-arrival, and as well as the healthcare system and essentially everything around that. We're really just trying to get the whole picture set here. And we do recognize that it does take some time for people to change. And 3 years honestly isn't enough, but it is a start. And as long as we have those recurring, like for example, the E-module, as long as we have that yearly, we're starting to change that behavior that people have.
So factors such as socioeconomic status and language barrier can make it really difficult to navigate our healthcare system. Therefore, we envision a healthcare system that is prepared to meet the needs of the refugee community by expanding resources and connecting patients to the necessary services more efficiently.
This will lead to better refugee outcomes by having proactive measures that promote accessibility and preventative outcomes.
Healthcare goes so much more beyond the hospital. The social determinants of health, such as income, race, and culture, all have intersecting effects on the care that patients receive, and this stress can compound over time. So when Amina walked into the emergency room, she was carrying a lot more than the physical ailment that she sought medical attention for. We see the first point of care as an opportunity to fulfill a vision of a healthcare system that is just as multifaceted as our health in itself.
All right, so just here are our references. We also just wanted to have a little shout out to our mentor, Tanya. She was very helpful throughout everything and always there for us when we needed it. Yeah, so that really concludes our presentation. We're open for questions now. Very excited to talk to you as we haven't really had a chance to meet the judges yet.
So first question, is that how you feel now, after being done with it? Like an elephant sitting on you at the beginning of the question and answer session?
I feel like the elephant's off now, to be honest.
Yeah.
That's a before picture.
Yeah.
Great, fantastic presentation. May I start? A couple of questions?
Of course.
For sure.
Yeah. So the first thing is, like, did you make these figures here that we're looking at, or did you get them from somewhere, or where are they from?
Our very own Thomas, actually.
Yes, I made them.
You made them?
Yeah.
You did, Thomas. Well done. They look absolutely fantastic.
Thank you.
Did you use any sort of theoretical framework? I know there's like symptom perception theory, common sense self-regulation model of illness representations. Any of that you consulted in the creation of these?
So I did part of the research for this, and what I did is I kind of looked at it in the like traditional Western like triage kind of framework. So I used like a physical assessment textbook and a triage textbook that kind of divided up different chest pain scenarios and other like common symptoms. But then I also looked for the way that pain is described in different cultures. Particularly, I looked closely at a text that was about how like Indian cultures and Indian language tends to, like East Indian, I explain pain, just because we wanted to make sure that the drawings weren't only based off of like the kind of metaphors that we're used to, but included metaphors that someone who actually doesn't speak English would resonate with as well.
Yeah, yeah, excellent. So I'm really interested in the use of these. So when it comes to representing signs and symptoms of an illness that one has, there's certain elements, like for example, timeline. How long have things happened? Would there be additional tools that would be used alongside these?
I think kind of the way that I envision it is we drew these drawings, but I could see even like a pain scale being added to this. I could see, I think a timeline kind of like Q would be a really great addition to. Like I kind of viewed our drawings as a starting point, but ideally like we could have a team of like other artists or just a team of nurses to give feedback so it could grow as it existed. So this could be like kind of a pilot version, but I could see like there being maybe a full poster. Mm-hmm.
Yeah, cool. And I think there's a couple of theories, particularly Leventhal's common sense self-regulation model of illness representations that would be really informative for this kind of work, just as an aside. How would you envisage people getting trained in the use of it? I'm not just thinking about the people coming in with the signs and symptoms, but the health professionals. Have you thought about that side of things?
That's what they were talking about with the e-learning module. Sorry, this is Victoria Monroe.
Right, hi.
Hi. So a lot of times I'm a nurse at the hospital. So when they bring in new things, we have e-learning, which is what they're talking about, that e-learning module, that once they had something, like after this study was done and everything was compiled and they had something to roll out, they would bring it into the hospital, and then it gets, the staff get educated that way through e-learning. So they have something to follow.
Right.
Because we already have like translators at present for patients that come in to hospital, that if they'll talk to patients beforehand, have family members come with, like the doctor that's involved. Like I work in the operating room, so in my area, they'll see their physician, they'll go to pre-assessment, they'll have a family member with them, they translate for them, they bring them day of surgery. So if we, in an emergency situation, brought a patient in, then we would have to call. We do have a 1-800 number that we can call and have a translator that speaks various different languages that can come if it's something that the patient can wait to have, if it's urgent, you have to go right away, you could have someone come and talk to them. But I think this module is excellent. Having the pictures, and like I said, when you're saying a starting point, well, of course, it's a starting point, moving on to having more pictures, like to explain more things. But I thought this presentation was excellent.
Thank you.
Thank you.
Sorry, I just wanted to add to that.
But I'll pass it on to others, so others can ask questions too.
I have a couple. I wish I had jumped in before Stephen, just because I too am interested in the pictorial tool. So I'm going to sound like I'm just kind of copying off what he had to ask. But I'm curious, in terms of just the efficacy of this, is this something that's been done anywhere else before, using these kind of pictorial tools? I suspect other institutions have used it before. And I'm just curious to know if there's anything out there on the literature as to, the presentation of the pictures.
I can, if anyone else wants to jump in, please cut me off, but I just happened to do the research for the pictorial section. I found the biggest one that was recurring was the pain scale, like with the facial expressions from like happy to like visibly upset. And I've seen a lot of pictorial tools to like help people remember symptoms. So like for stroke, I'd see a picture of a body with like various symptoms. But in my research, I didn't find as much that used more of like an expressionistic take to, because I'm learning another language right now, and I think like for me, when I looked at it, is that the way that you view the world is so much determined by your language. So I kind of wanted to take that approach into the drawings and really use like an expressionistic kind of take. Personally, I didn't see when I was doing my research.
Okay, cool, thanks. I will caution about the facial expressions. There's been quite a bit of research in psychology on this, that around the world, facial expressions differ in terms of our interpretations of them. There's Malcolm Gladwell wrote it, I believe, in his most recent book, I believe. He talks about some research that was done using the TV show Friends, and how they've shown the particular skits of that show to people around the world with it on mute, and just asked them to tell what they think the story would be. And the answers are incredibly diverse. So because we interpret the expressions. Actually, that was kind of the thing I liked about these pictures, was I didn't see necessarily an expression on the face. And because of that, I thought, based on my limited knowledge of reading Malcolm Gladwell's recent book, I like this, but I am curious to know if there's anything further on that. I do know that there is the Cantrell scale, where you have the ladder and you say, where would you like to be on this ladder? The first rung is the worst, the top rung is the best. Well, you probably want to be on the top. Okay, so where do you think you are right now? And you can do this for pain, or you can do this for well-being, or whatever the case may be. I'm not sure if this is something else that's been discussed in your work regarding this topic.
I personally wasn't aware of the latter, the Cantrell scale, but I could see too, like a combination of like, you know, maybe just a body of that someone could point to if they weren't comfortable, like, you know, with people touching them, or even like some kind of like time, or something to represent time that they could point to. I see it almost like a graph. This is just me kind of brainstorming, but even something like I could see a place for like something like a Cantrell scale with a ladder. Maybe like combining these elements would be effective, so they could tell you what and like the intensity or something like that. Yeah.
And if I may speak to the facial expressions, so these are also very basic drawings, and if we were to develop this pictorial element further, I feel like we could always, because we are focusing quite a bit on newcomers and you really never really know where anyone's going to come from, we could always like get together a focus group or really outsource a lot and try and find different perspectives to see and just try and find a universal facial expression or just image that everyone really understands well.
I think the benignness of it is spot on, because you haven't really shown the face to be expressing something, but it's more just the depiction itself. And is it Kean? Did you say you created these?
Yes. Yeah.
Okay, spot on. These are really cool. I gotta say, like the beauty of them is they're capturing, I think, a health perspective without putting a whole bunch of facial expressions, which could totally convolute everything, and that is really cool. And I'll also just point out. Sorry, I'll let you go ahead in a second, Stephen. I just wanted to add in. Thanks for presenting a budget as well. That's great. You know, there's always going to be questions as to how much any of this is going to cost. So good to point that out as well. Thanks.
Of course.
I agree with Barry on the facial expressions. Because pain can be read on the face. I mean, it's hard to do it like the pictures. They were excellent because they're going to show a lot of the signs and symptoms of what someone has. So I agree. I mean, you guys did a great job.
Thanks.
Moved it back so we can see all of them.
Yeah, it's true though, because you are showing, there is facials like showing, you know, when someone here looks like, you know, they're dry phoretic, they're nauseated, the green. The pain, you can see the wincing on the face, because that's a lot of times when you see a patient come in face to face, you're going to see a lot of the facial expressions and the patient sweating, and you can tell when someone's in pain just by their manners. So I thought this was great.
Awesome, thank you. All right, I think that's the end of the 10 minutes for the questions. Thank you everyone for coming. That was a great presentation, Team 3.
Thank you.
Well done. Yeah.
Thank you.
Yeah, thanks,
So
guys.
don't
That was great.
forget, 4:35 will be we'll be meeting in the